I can't see if it's recording yet, Rosie. Are we on? I'm going to assume so. Okay, brilliant. Right. Hi, everybody. Welcome to the Dorset Health and Wellbeing Board. It was going to be a meeting in person, but we thought that actually let's take advantage of just still being able to, because it's good to meet in person, but actually we seem to get a really good attendance virtually. So I'm hoping, and I hope most people are hoping, we can continue to mix it up, but we will meet in person one day. Won't be every meeting if we can find a way of meeting virtually. There are huge distances involved for some people, so it's good that we've actually managed to get people here today who wouldn't have been able to come along otherwise. The first item on the agenda is the apologies. So Fiona, have we got any apologies? Or
yes,
is it
Chairman. Hello, yeah, it's Tim Goodson, Eugene Afale and Patricia Miller.
Oh, okay, thank you. And though not a member of the board, I know Matt Pross is hoping to join as soon as possible. And of course, James, thanks for letting us know you might dip out quickly for an important event. Any declarations of interest? No? Okay. Fiona, is there any public participation today?
No, there isn't.
Okay, thank you. And are there any questions from members?
No, I've not received any.
Won't be asked already. Great. I see we've got a new member who's just popped up, who I haven't seen before. Is that Danny? Dr. Danny Farrell?
Sorry, yeah, still struggling to get mute off. Hello, yes, first time, still a year, 6 months on, can't work out the mute button.
No worries, lovely to see you. And you're the one I've spotted. I haven't got a big gallery at the moment. Is there anyone else I should have welcomed as a new member here? I know we've got some guest speakers. I'm just going to go to large gallery so I can see everybody. I think you might be it. I know you were caught up last time. Anyway, welcome.
Thank you.
Sorry, so I was on questions from members. I don't think there are there, Fiona?
No, there isn't. No, nothing received.
Okay. The next item on the agenda is the Safe School Review and the Future of Prevention in the Dorset Police. There aren't any papers for this because it's actually a presentation. So I see Caroline there.
Yes, hello.
Are you ready to take over?
Yes, if you're happy to.
And James is here, and we've got Lindsay. So I hand it over to the three of you.
Thank you, Chair. Can I just open up with a couple of minutes introduction then? I'm really grateful for time on the agenda. Hopefully we're very short, just to give colleagues an update of some work that's underway. Caroline and Lindsay are leading that work, but it's work that might affect us all and hopefully will offer something to everybody around hopefully improving our educational offering around community safety and health and wellbeing in schools. So I've asked Caroline and Lindsay to try and socialise some of the thinking with the two health and wellbeing boards, the Safeguarding Children's boards and the community safety partnerships. There is, in fact, going to be a partnership sort of symposium meeting in the coming weeks to sort of get closer engagement, and there has been a piece of work and a review undertaken, which Caroline will take you through. So really grateful for a bit of time on the agenda, hopefully not too short. Some colleagues may have seen this presentation in other boards, and apologies for that. But can I introduce Chief Superintendent Caroline Norton from Dorset Police and our colleague Lindsay Dudfield, who's the Chief Inspector, Head of Prevention for Dorset Police, where you will see over the coming months and years a greater emphasis, prevention being better than cure, of course. Over to you guys. Thank you, Chair.
Lovely, thank you, sir. Hello everyone. I'm just going to put our PowerPoint up. Lindsay's going to cover off the first few slides, which talks about the direction we want to take the prevention department, and then I'll just talk to you about the review that we've carried out around education services delivered by police and partners. Hopefully you can you see my screen?
Yes, thank you. It's not full screen. It's that's it. Brilliant.
That's it. Okay, right. I'll hand you over to Lindsay.
Hello everyone. As the Chief alluded to, I'm Lindsay Dudfield. I'm the Prevention Lead for Dorset Police. I've been in post since January this year, and on arrival I was given the task of looking at the Prevention Department as it stands currently, which is just over a year old in its current form, and trying to come up with a strategy for prevention moving forwards. So at the moment, this is the prevention structure that we have in Dorset Police. I'm responsible for looking after 4 of our inspectors with an awful lot of mixed business, if I'm honest. So I have the desk-based resolution team, which investigate desk-based investigations that don't necessitate an officer attending. I have the fraud triage team, our conventional crime prevention officers that offer crime prevention to victims of crime. I've got the adult early intervention team, which seeks to work with adults who repeatedly come to our notice, quite often repeat missing, or those people in the community with complex needs, mental health needs. Have the youth justice team and the safer schools team, which Mum Norton is going to come on to talk to you about in a moment. I've also got some strategic coordinators for some key pieces of work that we're involved in around missing people, mental health, drugs, death, and the real-time surveillance for suicide work that we undertake. And finally, I've got the integrated offender management team who manage some of our prolific acquisitive criminals in the community, the licensing team, our citizen policing team, which is volunteers, cadets and specials, and also the DRIVE programme, which is our very brand new DRIVE perpetrator programme for DA. So that's prevention as it currently stands, and my purpose really is to try and pull together a strategy for the future, which I've got to provide to the Chief in October. So the plan will be to come up with a long-term prevention strategy. So we understand we still got matters that we need to address today, but actually what should be our focus moving forward for 2030 and beyond? How do we try and address some of the social issues that are the causes of people being victims or perpetrators of crime as they sort of get older often? So in order to achieve this, we need some visionary leadership and political commitment. I say that because there's one thing I've realised since arriving in the prevention department, it's that it's very difficult to sometimes evidence what we're doing. It's hard to quantify what you prevent. And therefore, some of the wins that we may see may come in the next 5-10 years. They may not be immediate. So we need the commitment of people to stick with us, hopefully, so that we can do some long-term good work in preventing harm, essentially. And also, I think internally within policing, and I don't know whether this is replicated elsewhere, but we need to change the narrative. So for many years, due to austerity, I think we've responded to demand. We've sort of firefighted quite a lot, and actually now we've got an opportunity with Uplift to actually create, I think, some longer terms sort of sustained work that might prevent some of the harm in our communities. So that's the plan. In order to achieve that, I'm aiming to restructure the department into the 3 pillars of prevention, which I think is on the next slide. There we go. So we've got primary, secondary and tertiary prevention, which if you're from a health background will be very, very familiar because that's the language that health colleagues use. But actually in the primary prevention pillar, we're looking to address the root causes of criminal behaviour. So understand, you know, what makes the children who are in their homes of 5, 6, 7-year-olds now, how to identify those children who are likely to become victims or perpetrators of crime in 10, 20 years' time. How do we collect their ACEs? How are we trauma informed? And I think a key area for development here is understanding what will be our violence reduction approach in Dorset. So Dorset was not one of the 18 funded violence reduction units nationally, but actually what we're seeking to do now is understand the learning from those 18 violence reduction units, see how it's been done elsewhere in the country, and try and come up with some recommendations as to how we may approach violence reduction that will suit Dorset. And that's got to suit Dorset County and also BCP, which may have slightly different needs. So that's work that we're undertaking at the moment, but I foresee that very much in the primary pillar moving forward. So secondary prevention will seek to deal with the emerging threats, create good partnerships, diversions to keep people hopefully away from criminal behaviour. So here we will look at intervention, diversion and working with partners. And then finally, the tertiary column will be very much around acceptance that as much as we can do all the prevention in the world, we are still going to have perpetrators, offenders in the community that we need to manage. So here in tertiary prevention, we would seek to mitigate the risk and harm those people cause in the community. So if we go on to the next slide, I think the important reason why we're trying to go around and talk to as many partnership meetings as we can is to say, well, how do we link the work that we seek to achieve with partners? And I think when you look at the primary pillar, a lot of this work often isn't police led because we're talking about early years work, but actually I think policing has a really vital part to play in supplying some of the data and being involved in that conversation. But I think this is potentially where we may in the future link into health and wellbeing boards, public service forum. I think the secondary pillar of prevention very much links nicely to our community safety partnerships. And I've spoken to the Dorset CSP this morning and given them the same presentation. We'd like to get to the point whereby the priorities set by the CSP are the priorities we address in the secondary and actually also the primary pillar of prevention when we talk about intervention in schools. And then finally, I think the tertiary pillar of prevention very much links into reducing reoffending board. So that's how I see our work could link into the partnerships. And really the purpose of coming here today from my point of view is just to brief you, make you aware and start those very early conversations. So thank you.
Thank you, Lindsay. So that's really where we are, well, the approach we want to take with prevention. So I don't know whether we want to discuss it now or wait till we've done the educational part and then have a discussion.
Guided by you, Chair.
Yeah, I think several questions sort of come out of that one, but it's probably more detailed and you might be answering the questions that people have. So shall we let you carry on, Caroline, and we'll take questions afterwards?
Yes.
Watch the chat bar at this board meeting. People like the chat bar at the Health and Wellbeing Board.
Yeah, I can't see it at the moment because I've only got one screen.
Okay.
Again, I'll pick them up at the end. So
all right. Okay.
So if we move into education, so this started about sort of just coming up for about a year ago when it was discussions that Mr. Vaughan and I were having around, were we confident around our Safer Schools model? So what were the inputs? What was the delivery that they're doing within schools in Dorset? And also how are we working with schools? They're big community groups in Dorset. So that we started doing two pieces of work in terms of our neighbourhood response. What we've done is we've RAG rated all the schools in Dorset. So put them either as a red, amber or as a green. And in response to that, all our red schools have a dedicated Safer Schools officer who goes in and works closely with the school. And with the ambers and the greens, our neighbourhood teams are working closely with them. So they give a commitment that they'll go in, say, one day a month. They've got a close relationship. They're a point of contact for non-emergency issues. So it's about building that relationship. But the second piece of work we did was we wanted to make sure and just sort of reassure ourselves around what inputs were we providing to schools around policing and how we could influence education. And it was a wider conversation then around, if what are police doing, but also what are partners doing and are we overlapping quite a bit? So we commissioned a review with a company called Real World HR. We've used them previously in Dorset. They carried out a review of the Civil Contingencies Unit. So they're based in Manchester. It started at the beginning of last year, and they basically went around, spoke to schools, partner agencies and charities and providers across Dorset. It obviously coincided with the start of COVID and lockdown. So a lot of the work that they did was by questionnaire, and actually we got a much better response because of that. And in summary, they basically said that at a high level, there are shared common goals, common concerns, common frustrations, wants and needs from everyone. And it's a really complex problem. And actually, there's a real opportunity here that we can make some improvements. So they provided a really detailed presentation around it. So I'm going to try and summarise it on these slides. So first of all, I think it's quite helpful to look at what the education provision is in Dorset. So there's over 319 schools and colleges, and delivering a real mix up to the age of 18. So there's a big audience out there. But as a result of this work, we now know what's currently being delivered, what partners want, but also what the schools want and need. And I'll just focus on what the schools told us that they wanted. So they said that they need to know that they can access specialist and experienced support when they need it from agencies, and that they also want that support around how to deliver key messages to young people. They said that they wanted to be able to build relationships so they can safely share intelligence. So another thing that we've done over the last year is really rolled out a thing called Operation Encompass, which is about that information sharing with schools. And we've got over 300 schools now signed up to it. Schools wanted a service that was free at the point of delivery and that was affordable. Now, most of us are delivering services free of charge, but a lot of schools were under the sort of misunderstanding that they had to pay for services, and 66% cited cost as a barrier. So they wanted to know what was available and who they could access it from. But they wanted something really accessible. So not something that they had to try and schedule sessions with, that they could just really use some sort of online platform. And the schools also gave us topics and cohorts that they wanted included in safety education. So as a result of this work, Real World came back to us with 3 possible solutions in which we could do this. So the first one is a coordinated. So pretty much all partner agencies continue to do what we're currently doing, but we just try and improve the coordination a bit more. But for us, there were still a few concerns around that. The option B was combined. So this was really around what one agency perhaps would take a lead and would host some sort of platform where all agencies could apply the lessons, the learning that schools could then access. The third option is outsource. So this is around we pay for an external provider who can manage this service for us. So the approach we're at now is, so we now know what the schools want, we know roughly what partners want, but it's now moving into that space where we can have a good discussion with key partners to see what the views are and how much other partners want to get involved in that. So we've got our first meeting on the 30th of June with key directors from sort of children's services, education, health, fire. And I think that will really provide us with a good opportunity to discuss this further. And we're hoping from that we can agree a project baseline. You know, our hope is that we can deliver a sort of universal offering to all schools, but that perhaps it can be operated online so schools can access pieces of work. And for us, COVID has really helped. So as a result of COVID, we've picked the key areas that we're concerned about from a policing perspective. So things such as child sexual exploitation, county lines. And we've now recorded lessons and put material online using the 2 local authority platforms. So schools can go in and access them. And we can now record as well how many schools are taking part in that. So the recent County Lines Intensification Week, we knew that the number of hits, I think we have something like 4,000 hits from schools looking and individuals looking at that. So we know that's a potential opportunity. So we want to produce or complete that work within the next 2 months to really understand the partnership involvement. The next stage is really having that discussion with the educational establishment, so consulting with them further and hopefully agreeing what the preferred model would be and having a memorandum of understanding. And we'd like to complete that work by the autumn. And then the third phase is we'd like to run a pilot. So it might be that we just test the model, perhaps we look at a specific area that's of a high priority to all partners, and then we could try that out and possibly do that in January. So I think, and then the final part is we put in a project management framework within Dorset Police. We've got a small project board. So we really are just looking for that director level support, hopefully from yourselves and from the partnership meeting that we've got. As Lindsay said, we are delivering this across a number of partnership meetings as well at the moment, just to really get views from people. So I'll stop presenting. There we go.
Thank you. Thank you, Caroline. Thank you, Lindsay. Chair, I hope that was a helpful briefing for members of this board. Caroline, Lindsay, you will both probably know that you're very much preaching to the converted around prevention at scale as a central part of the integrated care strategy across Dorset. So, Chair, I hope that this is helpful in trying to show where policing and our links into community safety can make a difference, and how we're trying to get our work aligned to the work of the Health and Wellbeing Board, to avoid duplication and make further steps towards system-led sort of work across the county. So thanks, guys. I'm sure the chair and others may have some questions for you.
And certainly do, but I'm really grateful, and I'm really grateful. I see Teresa. I was looking to see if Teresa Levy was here, and she is. And I know that we've also got the other key partners. So we've got Mark from the fire service, and we've now got Matt, who the chief executive of Dorset Council, who, as I said, isn't a board member, but we always allow to speak, because there is so much that, as you were saying, this whole thing shows that partnership approach. It shows that people have been doing their stuff, but this is really sort of actually going to try and put it together. And I can see that you've got 3 options. Real world PR is great, so I've got real confidence in what they've been advising. But I'm going to hand it over to those leaders in those particular areas who might want to just ask some questions of you, now that we've got all of you here in one place, which is great. Who's got hands up? Teresa, hands up, and then I'll come. Who's the next one?
Thank you, Chair, and hello, Caroline, Lindsay, James. Good to see you all. And it is great to see the progress that I think we're all making across the various range of options that we're working on at the present time. And just, you know, talking with Steve Line equally around the Strengthening Services Board and the ways in which we're progressing that work around criminal exploitation and other matters, and particularly thinking about our contextual safeguarding work, which we've been working up together. So I know colleagues will be really familiar with this idea, but having conferences and interventions that are around place rather than around family is a really important progression for us. And so I think that bringing all of that into one place is really helpful. The one element I suppose I wanted to explore a bit more, and we will obviously, I'm attending with colleagues the workshop. I think we need to explore a little bit more about cost to schools. You'll know from your work that we are about 60-40 maintained academised at the present time, and clearly the national policy is to move towards total academisation, at which point fundamentally and frankly the money is all flowing directly into the schools and not into the local authority. And so in terms of some absolute basic offers, obviously all of our offer is equally free at the point of access for any safety matters, but where we're really looking at combining with schools, I think we need to have a really grown-up conversation with them about budgets and investment, if I'm honest, around their schools, their children and our place. So I'll be really look forward to having that at the workshop.
Great, thank you.
Thank you, Teresa. I think that those, like I say, those mature conversations are worthwhile. I want to remove where I can, where there is already investment from public services who have a vested interest in engaging with young people for prevention of harm, in effect, and community safety, to do that without adding burdens upon precious pupil premium budgets and various other budgets in schools. That would be great, because at the moment a charging model from policing is one that's not one I think is sustainable or actually ethical in the wider sense. So you really look forward to that conversation. Thank you.
So thank you very much. I got Mark, and then I'll come to Forbes.
Yes, thank you, Chair. No questions particularly. More of a thanks to Caroline, Lindsay, and Chief for the opportunity. I think it's really important that we can work collaboratively, strengthen our offerings as a whole, and be able to really engage with particularly our young people for that lifelong learning. And I'm really pleased that we're able to join you on the 30th and to be part of that. We're just really passionate about making sure that we're providing safer, healthier lives all across the whole of Dorset. So we look forward to being part of it. Thank you.
Thanks, Mark.
Thanks, Mark. I'm glad people are going on the 30th. Next one I have is Forbes, then I'll come to Sam.
Okay, do you want to? I think Martin had his hand up before me. Martin Longley.
Oh, did he?
Rebecca,
I am sorry.
There may be an overlap in our questions, so it seems only fair to let Martin go first.
I do apologise, Martin.
That's no problem. Thanks, Forbes. Just really a point about Dorset has a peculiarly large number of kids educated in the independent sector. Have the independent sector engaged with this process as well as you'd like to, and if not, what is being done to address that?
Do you want me to cover that? Yeah, so they were consulted as part of it, and that is the wider considerations I think we need to include. There was real disparity in terms of what schools were accessing services, and certainly with that sector and our relationship with them. You know, as I say, we've done the RAG rating, and most of the schools that obviously all the red schools aren't in the private sector. So yeah, absolutely, we are including them within it.
That's a really good point. Forbes.
Okay, thank you. So I'm sorry I missed the very start of your presentation, but what I heard was really encouraging. So I didn't hear a lot of mention of health. I may have missed it. So, you know, a key partner in all of this is health, particularly in that prevention element. If we're talking about, you know, the early years of life, etc., and children developing, then surely there's got to be a critical relationship between what you are doing and what health are doing. So there needs to be a several relationship structure, which primarily has yourselves, education and health, I think, working collaboratively, and there's a perfect opportunity now as we try to move the ICS forward. So I just want to understand what consideration you've taken to the relationship with health. And of course, that links exactly to what Teresa said about development of services, collective services at place. One of the issues that we've had before, and James is aware of this, is about information sharing. And you know, we've just got to get over that, quite honestly, somehow. And we need to make sure that happens, because actually it's a barrier for change at the moment rather than an enabler for change. We all hold important information sets, and it's less so in the most critical group, like the safeguarded group, but the others just believe that who are at risk. And if we're looking at how children develop, then we've got to spend time focusing on the needs of those individuals, because they can grow, as you know and tell us often, grow into, let's just say, troubled adults if they're troubled children for whatever reason. That is another thing. I'm just wondering what you might have in terms of ideas around quick wins, because we have spoken about this before. What could we take back to our colleagues in health, Danny, Martin, myself and others, about what the quick wins might be to actually get this going? That might not be costly in any shape or form, might be cost neutral, but actually it's just about collaboration and working effectively together. Thank you.
I know there's quite a few questions in there. Shall we just try and summarise them?
I could ask all afternoon probably about it actually, but let's distill it to those things.
So I think in relation to your last question, we know from the work that Real World did, a lot of the information that partners are delivering is out there already. I think it just needs to be coordinated, so schools know how they can just access it quite easily. And again, you know, I think we all appreciate we haven't got capacity to physically be in schools and to be able to answer every teacher's question. So I think the quick wins are around how do we find something really relatively quite easily that we can sort of download the material and schools can access it. So I think that's one of the key ones. I think the first question you had in relation to engagement with health, was that around the prevention model or to do with schools?
Well, all models really. We're talking about, you know, the life course here, aren't we? And we manage people through the life course, and you manage people through the life course, albeit at different points of contact, as do the various local authority services. So primarily, if we look at a long-term prevention strategy, we've got to get in the early years, haven't we? But, you know, prevention is about all arms, but let's focus on the primary prevention part for now.
If I can I come in there? So I think that actually the work that we're doing to scope what will our violence reduction approach be, I think is really, really key, because when we think about violence reduction, that isn't just, you know, we think about gangs and stabbings and that sort of culture in London. It's not about that. It's about violence in the home, on the street, everywhere. And I think understanding what our approach will be in Dorset, and that has to be with all of the agencies with health, because the people who are going to identify the threats early on are going to be your health visitors. They are going to be those types of people in the home. And at the moment, we don't pull all that data together, but I think we're already exploring the DICE. I always forget what it actually stands for. Dorset Intelligence.
Integrated Services, I think.
Yeah, so actually this is about big data, about having the health data, the police data, the local authority data, to be able to firstly identify what are those risk factors that are going to result in criminality, being a victim or being a perpetrator of a crime further down the road. So it's pulling together all of that information, I think, in the primary, then we can look to intervene and address. But I think we're not there yet, and that's why we're scoping to understand what that is going to look like in Dorset.
Is that okay, Forbes?
Yeah, no, it's fine. I think it's just got to get it on the radar, haven't we, in terms of those conversations. You know, it seems that you've really got a good process in place. So let's quite frankly look where we can best work with you. Looking, you know, we sit at our system partnership board. We talk about what's the vision, what's the strategy. Well, it is about population health. And if we're going to deliver population health at scale, we've got to be working collaboratively across the public sector to make the most of that. And quite frankly, we're better to start than our young people.
And just to check, I'm sure somebody from the CCG will be on at your meeting on the 30th of June.
Yes, they've been invited. I just need to do a couple of chase ups, but yeah, definitely we absolutely want CCG there. And I know Sam's on the line and he's been very supportive.
Okay, well maybe via Forbes, we absolutely make sure that that Forbes is aware of who's going, because it's the strength of this board that can actually make things happen at an operational level. I'm going to come to Sam next, and then Danny Farrell. Sam.
Yeah, thanks very much, Chair. So I was just going to make a quick point, but I've been drawn into the debate a bit, partly by Forbes's last response, and I think I'd absolutely support that we need to work more closely together, but we need to go beyond the data as well. So I was having a conversation with Matt Prosser this morning, where I can remember back in 2008, the NHS was poised to make some significant investments in parenting interventions to prevent the development of conduct disorder. And if we're really going to work upstream, we need to go back to that conversation about the evidence base and look at perhaps what has been stripped out of necessity from our local system, and have a really strong conversation about where we might put some of that investment back in, where there's really, really good evidence for longer term prevention of, you know, some quite serious disorders, which just add you know, problems to families, problems to people, but above all costs to our system. So I think having the integrated insights and intelligence service is a fantastic tool. It's a brilliant resource, and we will be looking to deploy those population health management tools and techniques in the system. But I do think part of the power of being in a board like this together is that we should be having honest conversations about where we've perhaps moved away from that opportunity to invest where it really makes sense. So that was my soapbox moment. Sorry, apologies. Really looking forward to the meeting on the 30th. I was just going to add to the presentation around the prevention model in policing. I think it's really interesting, and we're just about to take a paper through the systems leadership team in the integrated care system to look at developing a workshop to really rescope the prevention at scale strategy. So it's 3 or 4 years old. We took a sort of capacity building approach out of necessity, just to try to get as many organisations as possible looking at what they could do to really work around this concept of prevention, and what could organisations do within their existing resource. It's an open invitation, really. We'd like to see, you know, all of our partner organisations coming into that space. So as we start to take shape as an integrated care system, there's scope to perhaps widen the initial focus of that strategy, and I really look forward to those conversations. And Caroline, I haven't forgotten, I'm still trying to find a date for us and a couple of people to meet. It's in train.
Yeah, brilliant. Thank you, Sam. And if you can send us the date for that meeting anyway, we can get involved. We'd be really keen to.
Thanks, Sam. Danny Farrell, then I've got Simon.
Thanks, Chair. Yeah, it was just to support with what Forbes said about quick wins, what quick wins we could get, and communication. I think there are so many areas where we could improve communication across social services, the police and health. When you think of the toxic trio with domestic abuse, mental health and substance misuse, you know, our safeguarding meetings that we have with the health visitors, we have a list of families that we are keeping an eye on and supporting. And it would be good to see if the police have those same families, if the schools have those same families and social services, and then we can communicate and see what are the most appropriate ways of supporting those families. So yeah, I think if we could get over the barriers of communication about particular people and families, then it would really help us to move forward and get some quick wins. Thank you.
Brilliant. Thank you. And a very good point we're all struggling with, but just is common sense, isn't it? But great. Simon.
Thank you. So I'm chair of Dorset Community Action and here representing the voluntary sector. And really just wanted to understand, do you see a place for the voluntary sector in a prevention strategy? And if so, how are you integrating with them and how does it fit with what we're seeing today?
I think that's really interesting because actually when we were talking about even the education platform, we were saying, you know, as statutory partners, we could all upload, but I kept saying there must be loads that third sector can offer, loads that charities can offer to support and to assist schools. And actually it was knowing how to hook in. So it's brilliant that there's someone like you here, because it's exactly that. I'm sure there's a wealth of stuff out there that we could pull in, but half the time we just haven't mapped it or don't understand what's there. So I'd really welcome a conversation to understand what actually is available.
Okay, so perhaps we could take that after this and yeah, drop me a note.
Yeah, absolutely.
Okay.
Are there any more who want to contribute? I think quite a few actions have come out of that, but I think as a board, the most important thing that we can do is each of us who are leaders representing different areas is to commit to Caroline and the team and Lindsay, so that we do get people along to that key meeting on the 30th, that you do have the right people. And I'm really pleased there's a link up with Simon now. I'm looking maybe at, I don't know if because I know, Simon, you've worked really well alongside social care team at Dorset Council during this period. So there's probably some help that can be given with that information that they've got and what you have to input into the agenda here today. But I don't see I haven't heard anybody say let's do it another way. You've got options there, I know. So absolutely fantastic. Don't want to lose sight of it at all. If that can all be linked up with what Sam was talking about with the ICS and Forbes, and also that data sharing, which I think it was well over a year, James made the same point that Danny made at a Health and Wellbeing Board, was that we all share probably the top 300 families, if there is such a thing. I think that was only in Weymouth actually, but there are those people who we all have are spending time helping and working with. So Caroline and Lindsay, is there anything more you need from the board except a commitment that we'd love to hear back and put you on the agenda, put the whole team, hopefully the whole board, on the agenda for this work in the autumn? Because I think that was one of the deadlines. You said you wanted to have some pilots up and running. Is that too early to have some feedback? Because this is a quick win.
No, I think if we came back in the autumn, certainly then we'll know, you know, the sort of commitment from partners, and then how that's what agreements we've reached and how that's delivered into the schools. So no, absolutely, and very grateful for everyone's support. Very much appreciate it.
Brilliant. Okay, lovely. Thank you.
Thanks very much
indeed.
Thank you. Bye bye.
Thank you.
Thank you.
Right. Great. Next update on the agenda is the Local Outbreak Engagement Board update, and that's Sam. Are you there, Sam?
Thank you, Chair. So good afternoon, board members. This is just a brief paper updating on some of the progress that we've made under the Local Outbreak Management Plan. If you remember, the Health and Wellbeing Boards have been responsible for overseeing the sign-off as we've developed those COVID-19 outbreak management plans, and the board continues to play an ongoing role as we meet regularly through the Local Outbreak Engagement Board. So if it's okay with you, Chair, I was going to propose perhaps not to go into too much detail in the background paper. You've seen that we've updated against each of the 4 priorities. I was perhaps going to spend a little bit of time providing the board with a verbal update on the current situation, because we've had quite a substantial change since the time of writing of this paper. when we had to submit this because of the clearance timescales, I think the 7-day infection rate was around about 10 cases per 100,000, and it's now around about 52 cases per 100,000 for the most recent 7-day period. So if it's helpful, I was just going to update the board with the sort of current thinking of our response. Brilliant.
Thanks.
So cases are rising quite quickly. It is a concern. We've been meeting as a group of directors of public health, particularly the councils that have the highest rates, just to look at the characteristics of the current wave and what the response might be. I have to say that the predictions of our local Epicel modelling unit were that we were always quite likely to see this increase, particularly after step 3. So you'll be aware that under the changes under the roadmap, that degree of social mixing, and particularly mixing indoors, was always predicted to lead to increasing infections. The current infections predominantly are happening in younger age groups, so it's mainly affecting our 16 to 29-year-old age groups. And of course, another important factor to understand at the moment is that the progress that we've made with vaccination locally means that we're hoping that the link between increasing community infections and hospital admissions has been very much weakened. So we really hope that it's not going to be anything like the second wave that we saw through January, February in terms of the impact on our local health and care system. But nevertheless, it is a concern. You know, the objective in the local outbreak management plan is to try to maintain transmission as low as possible. Partly that's because the more transmission we have, the more the chance of variants spreading in the population. And that's predominantly what we're dealing with at the moment. I'm sure you're all aware that the current increase is very much linked with this Delta variant, which is renamed from its genetic name, which was B16172. The Local Outbreak Engagement Board met last week just to consider our current engagements and communication approach. And we've developed a proactive communications plan with Dorset CCG. That's going to be emphasising probably the 2 most important interventions we have at the moment. So apart from our immediate response to outbreaks and the support that we give to organisations experiencing them across the system, the importance of the vaccination programme, particularly second doses over the next few weeks, is absolutely critical. That's what gives you the maximum protection against serious disease. There's also a huge effort at the moment ongoing to get first doses into as many of the younger people as possible. And in this period, we're re-emphasising the importance of the community testing programme and twice weekly lateral flow testing. So just in this period until the review on July the 12th and the decision in July the 19th, we have to get as many people vaccinated as possible, keep a very, very close eye on what's happening in the health and care system in terms of the impact on our hospitals, but really continue to push those messages in the community, particularly targeting groups that are most likely to pick up the infection. So a third strand of the comms and engagement work is going to be talking directly to some of the local businesses and employers. So where businesses predominantly employ younger people, we're going to be going back out to reinforce the message about regular testing. And then the final point I was just going to make in relation to the paper itself is board members are asked to note Appendix A, which just sets out how we've used the 2 non-recurrent funding sources for the financial year 2020-2021. There was a test and trace grant, which was provided by government to support local outbreak management. And then further in the year, the Contain Outbreak Management Fund. So there's an annex which just sets out exactly how that money has been allocated and provides board members with a current summary of the spend. So that's probably all from me. I'm more than happy to take any questions. There are no recommendations. It's literally just to keep the board updated, Chair.
Thanks, Sam. It is quite an increase, isn't it, over the past week? And I'm really pleased that actually we're able to have the updates on the agenda. I appreciate that reports do have to go into Fiona, but this kind of thing does need it. It's so quickly changing. It's great to have a verbal update as well. I see Danny Farrell, and then I've got Forbes. with
Hi,
questions.
thanks, Chair. Yeah, it was just to ask, when you go into the businesses to reinforce the need for the twice weekly testing, would it be possible to just also reinforce the message about vaccination? In West Dorset, 77% of the population, the eligible population, have had their first and second doses. So we've got a few of the younger ones that we've still yet to reach. And we haven't got all their mobile phones because they don't always come to the doctor for anything. So we just wondered, we're thinking of reaching out to restaurants, businesses, to just try and spread that message. So if you're going in about the testing, I wondered if you could also reinforce about the vaccine.
Yeah, absolutely. It's a really good point. So it might not have come across clearly when I was talking about it, but the reason we've done this jointly with Ben Norman from the CCG is because we're trying to present both of those interventions as really, really crucial. So when we're talking to businesses about lateral flow testing, absolutely, if they've got a younger clientele as well, or if they've got younger employees, we'll just try to remind them to perhaps prompt and ask about whether they've booked in for vaccination. So really, really good point. Fully support it.
Thank you.
Is Forbes then?
Yeah, thank you. So a couple of things. First of all, yeah, just really to support Danny's comments, the importance of vaccination. You know, we absolutely should recognise the outstanding success of the vaccination programme across Dorset, and I have to say, particularly in West Dorset, you know, we've had huge support from returning colleagues and also existing colleagues, and also as a whole the public have been very receptive. So a good news story, but you know, it's not finished yet, and we need to keep vaccinating people. It's really important, particularly in those younger cohorts. And I think you may comment on this. We have got pockets in east of Dorset where the vaccination rates are not so good, and we really need to focus on those. That's not in this council's area particularly. I think the second point to make is that just reflecting the numbers, COVID has not gone away. And while the hospitals are not full of COVID, we are still having to assess people with possible COVID-related symptoms in primary care. So it is having an impact on primary care. And quite honestly, what we find with some people is when they ring up with symptoms that could be COVID-related, we say, have you thought about COVID? Well, they say, well, I'm sure it's not COVID. Because they tend to think I've been vaccinated, therefore it can't be COVID. So and of course it is having an impact on the other services that we're trying to deliver as well. So I would just ask people to bear that in mind, and you know, as usual, just reinforce the importance of continuing to follow the rules, because if people do that, then it will all come to an end more quickly for all of us with regard to the pandemic. Thank you.
Thanks, Forbes. Sam, is that all? Anything to add?
No, I just endorse what Forbes has said. I mean, you know, the vaccine is the way out of this. You know, lateral flow testing does provide a bit of assurance about current active infection and asymptomatic infection, but it really is about making sure we see this through and keep transmission as low as possible until we get to a point where we've got sufficient coverage in the population that we can suppress it. But it's no surprise that our refreshed local outbreak management plan is called Living Safely with COVID, and we deliberately chose that title because of the reality that unfortunately we are going to continue to see pockets of infection and probably outbreaks from time to time, but that huge potential risk to the population of epidemic transmission and translation through into, you know, huge numbers needing quite serious medical intervention. We hope that will be a thing of the past.
Thanks, Sam. Simon.
Yeah, only a quick one. I'm a volunteer at a local vaccination centre and have been since January. And I was there yesterday, simply in the car park, helping out. And I was struck yesterday by yesterday's people that were mainly in the 20 to 30 year category, how nervous they were. I've not had that with other age groups, but 4 or 5 as they drove into the centre actually said, really nervous. I brought a parent along. And then half a dozen were also visibly nervous. And I wonder if we're doing enough around reassurance and to calm some of those nerves to increase attendance and get the vaccination rates even higher.
Yeah, it's a really good point, and underpinning a lot of the support that we've been offering to the comms and engagement around vaccination is our behavioural insights programme. And one of the things that they will pull out from the evidence base is making sure that people have that assurance and that confidence. So we, taking the time to explain exactly how the vaccine's been developed, how it works, exactly what the likelihood of side effects are. All of this is really, really important in making sure that people are fully informed. I personally don't like that term, vaccine hesitancy, because it suggests that, the problem is with the person. Actually, we have a role to play in explaining exactly, how vaccines are made, the confidence that we have, the evaluation, the rigor with which they've been assessed and approved, and above all, their effectiveness. If you've got something that will reduce your chance of serious disease by 90% plus, that's the most effective public health intervention beyond basic sanitation measures that we have. I cannot put it more strongly than that. Everything else that we do is sticking plaster compared with vaccines.
Great, and I'm sure, Simon, you're being included on the comms, I hope. If not, you're absolutely, it should be escalating down through all the groups of your volunteers, all the communications. Are you receiving anything?
No, I'm not.
Okay, maybe Sam, we can pick that up with Kirsty.
Yeah, I'll feed that back. It won't be Kirsty anymore. Kirsty's moved into her ICS role, but I'll pick it up with Lucy Mears.
Brilliant. Okay, because they're out there. And the other thing I think we were going to do also was to include all the colleges and parent groups and the primary care networks. But Danny, you had your hand up again.
Yeah, it was just to say there is a huge difference in the age groups with the younger ones coming through, and I think a lot of it is social media and all the communications they have on there and anxieties around that. But 12, if we did a full day's clinic, about 12 would be near fainting of the younger ones, whereas in the older cohorts there was nobody. So I think anxiety is definitely fueled in this generation around lots of different elements, not just the fact that it's the vaccine for COVID, but it's an injection. But this morning, because it is either today or tomorrow, the 1,000,000th dose of the vaccine will be given in Dorset, the 1,000,000th Dorset dose. So we had a cameraman at the network clinic this morning and a couple of the other networks he was going to, and he actually interviewed a couple of the youngsters in the marquee after they'd had their vaccine. So hopefully we can utilise those videos to get the message out about how straightforward it was and pain-free and reduce some of the anxieties out there. But I think, yeah, the more engagement we can get with people on our Facebook pages where we're putting information on about the vaccine as well, then we can get that message out.
Brilliant. Well, I hope that's all getting linked up with the comms team from the board, the outbreak management board. But anyway, that's another one. Maybe. Oh, is Kirsty Smith?
I'll take us back to Lucy
Kirsty
Mears,
Smith.
who's now.
Brilliant. Okay, fantastic. Right, are there any more? Simon, you wanted to say something again? Or is that an old hand, a legacy hand? I think it must be a legacy hand for Simon, but he's frozen. Okay, I'm going to move on, Sam. Thank you very much for the update. Unless Simon's coming back, I don't think he is. We'll move on to the next one, which, oh, Simon, you are back. Was that a...
Sorry, yeah, just an IT glitch. Yeah, just very quickly to shorten your communications on this, but Jill Foote already has a very good communication link with all the PPGs, or with a lot of the PPGs across Dorset, and a lot of PPG members are also volunteers at vaccination sites. So there are newsletters and there are regular communications that go out through the CCG to practices and volunteer groups with an interest in healthcare. So that might be a good mechanism.
Okay, great. Thanks, Simon. Okay, I think thanks, Sam. We're going to move on to item number 7, where this is Sam and Paul.
Thanks, Chair. I think it's just, yeah, I think it's just me introducing the paper. So this is a brief paper which is just updating on the current progress with some of the developments as we move towards establishing the integrated care system. And it's intended to bring Health and Wellbeing Board members up to speed with some of the ongoing design issues that the work programmes are facing. There's one key recommendation in the paper, and as Director of Public Health, I'm seeking to make that decision under delegated powers. So this means that I'll introduce the paper, but I can't take part in the subsequent debate. So I'll be looking to the board for their minded to decision on the one recommendation, either to support or not to support. But for those reasons, I hope you understand I'll set it up, but I won't be then influencing the recommendation. Is that clear to board members?
Yeah, it is, I suppose, to those of us who've been operating under this. But I was just wondering, Sam, before we lose you, I know you'll run through the paper. I had a quick question on the recommendation, because there's a recommendation at the beginning of the paper, and then we get down to the end of the paper, where there is a conclusion. I thought there was a conclusion in 2.7, but that might be in the appendix. So maybe that is something which has happened under the appendix. So the recommendation you're looking for is on the front page of the paper, Dorset, the update paper.
Yeah, so just to be clear,
Okay.
There's a short cover paper which is called Update on the Integrated Care
Yeah.
System. And then as one of the background papers, I've included a paper that was written by Rebecca Kendall, which
Yeah.
was to go to all system partners, really setting out
Okay.
some of the next steps. But the key recommendation that we're looking for board members to provide a minded to decision on is that the board is asked to support the recommendation to hold a development session
Great.
within the next couple of months, just to consider how the Health and Wellbeing Board will work with the Place-Based Partnerships Forum of the Integrated Care System.
Great, thank you.
Okay, brilliant. So if that's clear, I'll go on and just talk a little bit around the paper. So this really just makes the point that the design work that's necessary to get us to the point by April 2022 of legally establishing the integrated care system is obviously taking place at a pace. There are several work streams in train that are supporting how the future integrated care system will look. And one of the most relevant work streams to this board is the place-based partnerships work. So for some time now, the guidance that's been coming out, including the original paper in February, was talking about the importance of place-based leadership and that this would form a key part of the decision-making landscape around integrated care systems. And it talked about this duty on a new partnership forum to collaborate with the integrated care system statutory body to improve outcomes for people and communities and reduce inequalities in health. So what this paper's essentially recognising is that the parts are moving very quickly. The Health and Wellbeing Boards haven't always been mentioned explicitly in some of that guidance that's come out as the centres started to provide some guide rails as to how integrated care systems develop. But there was publication last week, again, outside of the timelines for pulling this paper together, that was quite helpful, called the Integrated Care System Design Framework. And it stated that the ICS partnership will be required to develop an integrated care strategy, that this should be built from the bottom up through joint strategic needs assessment and focus on improving outcomes, reducing inequalities and addressing the consequences of the pandemic, for example, for local communities. And it also makes clear that there won't be legislation to support this, but that the partnership will be based on some core principles. So I think that's quite helpful in a way, because it suggests that there won't be an unpicking of the legislation that put health and wellbeing boards in place. So I think this discussion for the Health and Wellbeing Board is to continue for us to have some time to work through what is the ask of this place-based forum. You know, what role will health and wellbeing boards play? Because I would say that they are the natural leaders around health and wellbeing needs for their local populations. but how are we going to make sure that the board is still in the best possible position to offer that leadership and influence as this place-based partnership starts to develop? The initial guidance suggests that the partnership membership will be including local NHS members, the councils responsible for social care services, members of health and wellbeing boards, other statutory organisations and voluntary community and social enterprise organisations. So I think there's a fair degree of flexibility in who sits on that partnership forum, but some of the key issues for me as Director of Public Health are how do we get that really, really sharp lens and focus on the most important outcomes? And then how do we continue to influence the integrated care system statutory body, which will then have a duty to prepare a plan to address some of those issues? So I was going to pause there and allow the rest of the board to pick up on some of the points in the paper. I don't know if colleagues from the CCG, Forbes and others might want to come in and contribute to this point, but I'll step away and then I'll come back in when we're ready to consider the Minded To decision.
So is anyone wanting to come forward? Forbes, would you like to? I know we don't have Tim here today. Yeah, Forbes.
Yeah, thank you. I mean, this is very much work in progress. I think I would have to say, and Sam really has outlined the steps. Matt's obviously very involved from a local authority point of view and leading on a number of areas of work with Tim and Eugene from Dorset Healthcare. I think it's up to us to make it what we want it to be. So there's a degree of top-down design, but actually let's locally develop what would be best for the needs of the population of the whole of Dorset. And if we then focus at place, I think the role of this Health and Wellbeing Board is to oversee what happens within the Dorset Council area and make it the best it can be using the collective resources, the Dorset pound, as we say, that we have at our disposal. So for me, the conversation is about what's the best way of the Health and Wellbeing Board being completely included within any work that the ICS is doing for the population that it serves, and quite frankly steering it as much as possible. And I know certainly my colleagues within health are very supportive of that, and in the subsection my colleagues within general practice are equally supportive of that as well, and that's where we can make a difference. Very much back to our first presentation this afternoon at neighbourhood and at place, for our communities together. Thank you.
Brilliant, thank you. I'm going to bring in Laura.
Thanks, Rebecca. Yeah, just really echo what Forbes said, and I think the recommendation is that we hold a development session, and we can see from the huge amount of information that we've got in the back papers and the report itself that this is an enormous piece of work. This is an enormous sea change, and as Forbes said, this is our opportunity to really work out what we want from the ground up and what we need and what the people of Dorset need. So without going into too much detail on the paper itself, because the recommendation is that we hold a development session, I suppose, to do just that. So certainly I'd support that. I think it's a really good idea, and just welcome having that space to sort of take a breath and go, okay, here we are. How do we do this? So yeah, I'm definitely in support. Thank you, Chair.
Thanks, Laura. I was going to ask you, Matt, but you put your hand up, so thank you very much.
Only polite, Chair, and thank you for allowing me to speak as a non-member of the board. And it's just, I mean, echoing what Forbes and Laura have said, this is really important. If Sam had been on the line, just confirming this, there's a mirror report, I believe, going to the other Health and Wellbeing Board in the BCP area, because it is really important that we get this piece right. There's a huge opportunity for us here across Dorset as a system to do something really, really special and something really different, but it is going to take effort. It is going to take some time and investment. So if the board is prepared to put that time and investment into that development session, I think it would be richly rewarded in one sense with the outcomes for that. But from my perspective, we're getting lots of central directives, as Sam mentioned, coming down. I still have the regional directors' words ringing in my ear: comply or explain. We either comply with that central directive or we explain why Dorset is going to be different. And I think I hope that Dorset is going to think about how it can do some things differently through this process for the benefit and the best outcomes of all the people to whom we have a duty, which is the residents of Dorset. So thank you.
Brilliant. Thanks, Matt. And I think some of what you just said, and I've reflected on it. You know, you're the chief executive of the local authority and not on the board, and this is something where actually it is there is some madness that we've gone through, but this is the time to actually put some of that into the right place so it's the most effective, because we've got to have the right people in the room. And if we get the right people in the room, and it might not be all of us, who knows, but that day, and it might need to be a day, I don't know, but that development session has to have a really good outcome. It's got to be honest, and we've got to get to actually what we really need to do. And there might be things that the health and wellbeing boards have done in the past, but need to create some space to do the ICS in the way that is absolutely the right way for Dorset and for BCP. It might be that there are different ways of working with the other health and wellbeing board. All of this needs to be explored, but it needs all of us to go on that journey, and it will need to start with a really down-to-earth discussion about what it means, and a realistic discussion. I haven't seen any more hands. And the way that this now works with the delegated responsibility for taking through a recommendation means that we need to affirm that we accept the recommendation which is on the paper, that board members are asked to support the recommendation to hold a development session in the next 2 months. And note that is 2 months, because we do have a really restrictive timetable. It's not our timetable, it's the government's timetable, to consider how the board will work with the place-based partnership forum of the ICS and its statutory body. So unless I see any indications to the contrary, or do I need to see everyone nodding? Says this is a decision.
Agreed.
Agreed. Shall we? Yeah. Okay. Brilliant. No one to the contrary. Apparently, I must say, does anyone abstain? And is anyone against? So Sam, you've heard what we've all agreed. Is that what you are going to agree in your delegated responsibility role?
I recognise the board's minded to decision, and we'll make sure that that's reflected accurately in any minutes. And obviously that's a decision that I'm taking under delegation. So I'll work with Fiona King to make sure that that's recorded, and thank you, board, for supporting.
Brilliant. Great. Thank you very much indeed. Okay, and watch the diaries, because 2 months, that's not a long time to try and get all of us in a meeting. Should I ask, now that I've got everyone here, to see if there is a preference on whether this is a meeting in a room or whether it can happen virtually? Sam, this is outside the recommendation, so I'm sort of looking at you and maybe Matt and Forbes to sort of have a think about the best way. The best way to get everybody is virtually, but is it the right way to have this type of a conversation? Any feedback?
Chair, it's James. I just think we, as we see the Delta variant taking a bit of a hold in the county, we're seeing infection rates increase. We're not seeing a link between infection rates, hospitalisation and serious illness yet, but I think we are monitoring that closely through the strategic coordinating group and obviously all the health forums. So it might be sensible at this stage to plan to do it online rather than try and do it face to face and then cancel. We do get good attendance. Yeah. That would be my view.
Sam.
Yeah, I mean, this isn't a problem or an issue that will be resolved immediately. I think it's about recognising that we need to have the time to have that discussion and understand what the ask might be. So sure, we can do that online at first, and then if we can physically get together later on in the year, you know, some of these questions will still need to be sort of answered further on in the process, I think, as more of the guidance comes out and the ask becomes clearer. But I think let's start the process and let's have some sort of sovereign time as a board to start to get to grips with this. That'd be really helpful.
Okay, Forbes.
Yeah, basically, I would fully support that. I think at the moment, while it's still unclear, it's quite difficult to plan for a face-to-face gathering with public sector leaders in Dorset all sitting in the same room. Let's be honest, that's not the best message, perhaps. So yeah. I think let's plan to do it virtually. What does quite work well, so we get, a breadth of feedback is if we do the breakout rooms, which can be done as part of our gathering, and actually, therefore, you get a broad church of views rather than just a few speaking.
Brilliant. Okay, I'm not hearing to the contrary, and I totally agree with you. I think getting the right people in the room at this start at this time is the most important rather than not. So thank you, Sam. I'm going to leave that with you, but of course it's not just you needing to arrange it. It's others as well. So I'm sure with Matt maybe and Forbes. Thank you very much. Right, we'll now move on to item number 8, which is the JSNA. And I've got Paul and Natasha joining us for this, I believe. I can see Paul and Natasha. Yep. Great.
Thank you, Chair.
Okay.
I'll hand over to Nat very shortly, who's kindly joined us this afternoon, who's going to give us an update on some work we've been doing or Nat's been leading with ICS colleagues looking at health inequalities, which will help inform the development of an ICS strategy around health inequalities. Over to you, Nat.
Thank you, Paul. 1 second while I just set up some slides. My Teams has got a little delay on it, so I will start talking as they go up. But thank board members for inviting me here this afternoon to update on this work. Okay, hopefully you can see the slides now.
Yep.
Do shout if you can't. Excellent. So as Paul said, I'm Natasha. I'm Senior Analyst at Public Health Dorset, and I've been leading on developing the JSNA panel and workshop process and doing that virtually at the moment. And we've been working with the health inequalities groups and ICS colleagues around health inequalities. So just give you an update on the progress so far. So just some context for the panel discussions and the work that we've been doing. Although Dorset is relatively healthy and affluent, we do see inequalities within our area. So although generally our life expectancy is better than England, we do see variation of just over 11 years in life expectancy for males and around 11 years for females as well. It's also well established that deprivation is linked with inequalities, and we have areas within our council area that are experiencing deprivation, particularly around Weymouth and Portland areas. So it's a really important topic, and the Health Inequalities Group are working on developing a strategy which they'd like the JSNA workshop process to inform. So we followed the virtual process that we developed last year, and I think I've presented to you previously around the end of life care work and physical activity panels. So we use systems thinking as an approach to explore a topic in an interactive way to develop shared understanding from a variety of perspectives on the challenges in that area. The first cohort of this was held with integrated care system programme leads, and it's noted that health inequalities is a really complex topic with many perspectives on what the challenges are. This cohort is a starting point to think about the health and care system perspective. So we held a first workshop a couple of months ago where we brainstormed some of the local drivers and barriers involved in health inequalities from different perspectives. I developed that into what's known as a systems map, basically a diagram of how these drivers and barriers interact with each other to result in outcomes. Gave back for feedback, and we based that on the discussions in workshop 2, where we looked at refining that picture and surfacing some more insight about health inequalities locally. And the final output from that, which I'm sharing with you today, is a further refined systems map and some key insights identified from the discussions. So just starting from the initial conversations, obviously with such a complex topic, we had quite a broad discussion in the first workshop, which surfaced loads of insights into local drivers and barriers. We touched on a really wide range of topics such as regional economic development, children's development, youth justice, health literacy, access to health, really, really broad range of ideas and perspectives. So collating all of that information and that discussion led us to 3 key insights from that first workshop. And this is what formed a basis of workshop 2. So the first one, which I've already mentioned, was we had numerous steps, connections and feedback loops. In systems thinking, a feedback loop is explaining how an outcome or a behaviour is perpetuated within a system. So it really highlighted the complexity of the health inequalities challenge, but also its importance to our system. Through our discussions, we identified that living and working conditions were recognised as one of the key drivers in our health inequalities system locally. And also a key barrier was an ability to resource harm reduction or prevention activities. So we took these initial ideas and discussions into workshop 2 to refine and discuss them further. So I'm going to share you snippets of the map as I go along because it's quite complex. I think probably one of the most complex ones we've done so far. But the first insight, ironically, was the complexity of the drivers. So as I discussed, we covered a wide range of topics involved in health inequalities and how there are many interconnected drivers across the life course. So to kind of explain this in a simple way or semi-simple is we've adapted a model of a life course ladder from MacArthur Foundation Research Network, and that describes how some of the key living and working conditions at various points in the life course interact with health outcomes and vice versa to create this interconnected health and wellbeing life course. We also recognise the importance of wider determinants such as inequities in housing, natural environment and built environment, and power and discrimination. So that's also included on the end of our diagram to show how that also impacts people's outcomes and opportunities. The second insight was focused around strategic decision-making processes. So there was a consensus in some of the discussions that a key leverage area in our systems, an opportunity to help transform things, is around strategic decision-making. And we expanded our discussions around prioritisation and resource allocation from the first workshop. So we tried to capture the discussion around how health and care service development, as well as economic and community development in a health in all policy type approach influences system prioritisation and resource allocation. So there's a lot of discussion about service demand and how this can lead to focus on efficiencies and response to deal with system pressures. And this challenge is something that's often raised in some form in a lot of the panel discussions we've done, and its impact on resource allocation to activities or interventions that are upstream of an issue. We try to capture this concept that, as we showed in the first insight, the complexity of this challenge means population health is not something one sector can improve on its own. So our third insight from the workshop 2 was that there was an agreement that meaningful community engagement is a really important part of the system. And we had discussions about the importance of listening to communities to truly understand need, as well as the role of incorporating co-design and co-production into development and prioritisation in processes in a meaningful way. it was acknowledged that if we don't have meaningful community engagement, then there's a risk we could prioritise factors that are important from our service perspective and potentially miss leveraging change on factors that could transform population outcomes. So this made me reflect on the end-of-life care insights that I shared at the last board meeting, where that was all about keeping what matters and conversations at the heart of what they did in end-of-life care. Really resonated for me, is hearing these conversations in the second workshop. So that's an overview of where we've got to with this work. It's a starting point, and we'll be developing this process further to incorporate wider perspectives on the challenge through an online discussion tool. But I'd also welcome any feedback on what I've presented today and our initial diagrams. I'm really interested in what your key insights around health inequalities and if you have any different perspectives. And we'll be developing the workshop outputs into a narrative, and that will be published on our JSNA website. Let me hopefully end the slideshow so I can see you all.
Hi there.
Hi.
Dog bark just at the wrong moment. So Nat, you like feedback on the presentation, and what is I don't know if you've got sort of some just in layman's terms what the feeling of some of those focus groups were, because some of what you said back is quite complicated, and it'd be interesting to then see maybe for the directors in social care and children's, or maybe Laura can add something to some of what you've sort of instinctively heard back from the panels. Would that be okay?
Yes, great. If you want me, apologies for any technical language. I do get stuck into the systems.
No,
thinking
don't worry.
approach,
It has to be done, but
yeah,
you get a feeling for something, don't you? That would be
I
quite
think
interesting.
the key messages coming out to me were how complex the issues involved in health inequalities are, and we've had some of discussions before about how there are different points in people's lives that influence their outcomes, and things are interconnected and can develop over time, and really need to look at different points in the life course and how we can intervene. But it's not just one sector or one issue, it's about working together. Also discussions about how system pressures and responding to those can influence where we prioritise and affect our ability to resource interventions. And thirdly, that listening to understand is really important when understanding community needs. So hopefully that's a quick summary of the insights.
That's fantastic. Thank you very much indeed. Sam.
Thanks, Chair. Thanks, Nat. Really, really useful. And I was just going to reflect on, you know, this is a complex topic, and some of us have been around this for a long, long time. But one of the power of that insights panel process is that what you're then seeing is exactly how those participants characterise the issue as it occurs to them in their sort of everyday practice. And of course, there's a whole range of people in there. So I think the way that's been boiled down and crystallised into, you know, 3 key issues for us, it's actually a really, really good fit with what I was previously talking about in the earlier paper around how we start to go into the integrated care system with a bit of a recognition of how we build this up. So what I'm hearing is very, very strong support for some of the common approaches across both councils and the current CCG, actually, about the importance of listening to and working with communities rather than coming up with imposed solutions. You know, it is complex, and we all need to be clear where organisations and agencies can have influence, but perhaps there are times when that conversation is a conversation with communities and people about what they can do for themselves and recognising, you know, their strengths and their assets. But the thing that stood out for me is what you said about the barrier around investing in prevention and getting upstream of some of this. having this connected back to resource allocation is going to be one of the most important things that we can do as an integrated care system going forwards. And that's partly what we're going to have to put together and make work in the Dorset system. So if you remember in the previous paper, we talked about the need to build up from the bottom, looking at the JSNA. This is just the first stage of the process. It now needs to feed into those strategic decision-making discussions about where would be the key outcomes, where we want to really shift and make a difference, and what are the resources that would be needed to make that difference. Thanks, Nat.
Thanks, Sam.
And thanks, Sam. And that's the tricky bit, isn't it? And I know you did say that working on a JSNA wasn't going to be put into legislation, but the big question would be, why wouldn't you? So all these years of that work that has been going on is going to be really helpful. Vivian.
Yeah, thank you, Chair, and thank you, Natasha. Really useful to see, even if it was very a complex presentation. Really useful to see those core issues that you've pulled out. I mean, and it really does link to back, as Sam has said, to that ICS conversation that we need to have, doesn't it, about how we work with our population. And how important it really is to have that honest conversation with people at a time. How do you have those conversations at the time before it really matters to people, before they reach those key points in their life journeys? And how do we have that honest conversation that's based around what's the collective resource we have together? And how do we want to invest that collective resource in the community and that place? And how do we do that, across our different directorates and across our different portfolios, to making sure that we are truly listening to our community? So that system work, very powerful, and to have done that level of engagement and then sort of to decipher that out, I think that will that should very much play into the next conversation that we do have around how do we work as a system to support our population in a sort of true co-produced way. So yeah, really helpful, Natasha. Thank you.
Thank you, Vivian. I agree. I think I hear and reflect a lot from the discussions the importance of conversation in a lot of these issues.
Thank you, Vivian. Hands up, I've got Simon and Laura. Simon and then Laura.
Okay, yeah, thank you. So I represent the voluntary sector here, but no one can speak personally for the voluntary sector.
Simon, I don't know if it's just me, but you're a bit crackly.
Can you hear me better now?
Maybe if you turn your video off, it might help.
Can you hear me any better now?
Yes.
Yes, that's better.
Yeah, good. So I do represent the voluntary sector, but no way can I represent all the views of the voluntary sector across Dorset. It's very diverse. And you've talked a lot about engaging with communities, actually both on this and the ICS. And it strikes me as how you best intend to do that. Now, I know there's good models out there already. So, for example, strikes me that the approach to COVID response, which engaged with a number of voluntary organisations, plus working very well with CCG and Dorset Council, etc. And that was a very good approach to engage with communities across Dorset. And I wonder if something like that could be considered or adopted as part of this work.
Great, thank you. Yes, as part of the JSNA workshop process, I've been trying to ensure that where we can on panels that we involve voluntary sector and also community representatives and patient reps. And I think that's really valuable to add those perspectives within the conversations in the room. I think as part of the health inequalities work, it's definitely something that we want to look into and how we can develop this further and develop those conversations. I don't know if Paul wants to add anything from the health inequalities point of view.
If I might quickly, I think we're keen to do some more insights panels work around health inequalities. This first one was done with ICS program leads, keen to do similar with other stakeholder groups, but mindful that there's a lot of people with views around this agenda. I think we'll also look, as Nat referred to in her introduction, I think we'll also look to perhaps do some online kind of engagement work using some sort of a tool. I think it's called Padlet, which the physical activity strategy work has used to good effect to engage with communities through getting discussion around key questions.
Thank you.
Great, thanks, Paul. Laura, you had a hand up.
Thank you. Yeah, my point is a really simple one. I support the good work that's happening. Happy to get involved, get stuck in wherever helpful. The point I just wanted to make is if we are co-producing and if we are engaging with people, then our language has to not be corporate and buzzwordy. We pretty much, by and large, on this call, all understand it. Not all of it, but most of it. And so I just wanted to make a plea for people who are not, who do not have their heads in this all the time. We've really got to have regard to the way that we talk, because this is a public meeting, and I imagine that a lot of, you know, if people are watching this, some of the words that we've used are not words they would encounter every day and would be slightly, well, completely incomprehensible. So just a plain language plea from me, really.
Okay, thank you very much indeed to Nat and to. Is there anything else you wanted to add, Paul? What's the next stage? Anyone?
In terms of the JSNA work, as mentioned, we're going to do some further development to bring in wider perspectives. So using the online discussion tool like Padlet and running a further cohort of workshops, hopefully.
I was just wondering, and I know we have to create space to do this, but just picking up on what Laura said, we hear in all sorts of different places about the importance of health inequalities, and we need our public to understand what that is, and that maybe they're part of it or maybe they're not. How do they understand that there might be an issue that we can help them with, or there is an issue that prevention can help with? I don't know where this happens, but it is something to unravel and to create a plain English version of it. It's not a version, but a plain English way of approaching it, because the creation of the ICS, i.e. no one understands what the ICS stands for, but putting health and social care together now means more to the public than I think it ever has done before, due to the high visibility of the need for social care during the past 18 months. So is there a way of actually putting health inequalities into a place that can be understood by all, and what we're trying to achieve isn't something that we're doing academically, but actually means something on the ground? And perhaps that's something Danny or Forbes might be able to help with. What's the language on the ground that you would actually talk to people who were visiting their GPs or getting in contact with that early help agenda? It's just something I think that somewhere we need to have a look at it. It might be one of the committees within Dorset Council that needs to have a look at that. I'm not sure. Any ideas, or should we think about it? Paul.
Thank you, Chair. Happy to be giving that some thought and would welcome comments and inputs from colleagues. I head up the ICS Health Inequalities programme, and the work that Nat's been doing with the insights panels will feed into strategy work that we're looking to develop. This first sort of phase of the work in the ICS programme is very much focused on a sort of professional audience. As we look into next year and beyond, I think there's a real desire to engage much more widely with communities. That will necessarily mean we will have to address the language and communication challenge that you just set out. And I think alongside that, we also need to kind of get a balance between our conversations as professionals around health inequalities, which tends to take us towards needs and deficits almost, and work out how we balance that with perhaps more empowering asset-based approach on life.
And I think one of the items you were going to bring to the board at some stage was about asset bases. Yeah. Okay. Well, maybe I'm being a bit early. Forbes, have you got something to say on this one?
It was just a comment about the language. I absolutely support the comments that were made. The Health Inequalities Group, is probably the place to test it, really, isn't it? And we, for this stage, we certainly have GPs sitting on that group, and it's quite a wide membership. So that's probably the best route. I would just note that comment has been made in the Health and Wellbeing Board and take it back to that group, because I know those leading that are very aware of the language being appropriate and, quite frankly, understandable. And obviously that'll continue to develop as you move to the next stage in your work.
Okay, thanks very much, Forbes, and thank you both for that presentation and bringing us back to the fact that everything needs to be based on what you're finding out. So that's really helpful. Brilliant. Thank you both very much. That was a fantastic presentation on the JSNA. We are now moving on to item number 9. Have we got Rupert here? Yes, we have.
Yes,
Great.
hello, Chair.
Hi, Rupert Lloyd is going to give us an update on physical activity, which is another key aspect of the board's prevention work. So, Rupert, over to you.
Brilliant. Thank you, Chair. Just bear with me for a moment while I share my slides. There we go. Has that come through, Chair?
Yes, it has. Yep, a movement for movement.
Great, lovely.
Sounds
okay.
Good.
Yep, thank you. Thank you, Chair, and thank you to the board for giving me the opportunity to come and speak to you this afternoon and socialise and share some of our thinking around this. I've been working with Charlie Coward at Active Dorset. I'm part of the team at Public Health Dorset to apply the systems thinking approach we've developed to this topic, to physical activity. So I guess my presentation kind of leads on quite neatly from Nat's in terms of being a complex problem that lots of members of the board have been around for a long time. And I think last time Charlie came and spoke to the board, we just finished a second workshop with stakeholders. So what I wanted to do this afternoon was bring you up to speed on how we progressed through that process and to give you a little bit of an update on where we are at the moment. So I'm going to speak for about 10 minutes and I wanted to cover 3 things. I wanted to go over the story so far, what we've done so far, say a little bit about our current focus, and I'll talk about what Charlie and I are focusing on the moment as part of developing the strategy. And then I wanted to conclude, if I could, by kind of sense checking that with the board and also asking for your help. But I'll say a little bit more about that later in the presentation. So to kick off, during the spring of this year, we set out to start building, as Nat said, shared understanding of our challenge by trying to answer or tackle the question of what is it, what's the system that drives or shapes inactivity locally. So we used Padlet, the online conversation that Charlie spoke about before and Paul mentioned earlier, which is still open on Active Dorset's website at the moment to gather views from stakeholders. And we also held online workshops with stakeholders that lots of people very generously gave up their time to take part in. And what we wanted to gain from that process was, I suppose, putting it simply, insight into what people who have particular expertise or perspectives or experience have, what their insights are on what the most important parts of the story are that explain why we see the levels of inactivity across Dorset that we do. And the way I kind of think of this process of systems thinking and creating a systems map is we all have our own kind of perspective or piece of the jigsaw puzzle, if you like, that explains a challenge, but we might know what's on our piece of the jigsaw, we might know our perspective, but we don't necessarily know or see or understand what's on others' piece of the jigsaw. So the value of systems thinking is on committing it all to paper and sharing all of those different perspectives. So this is what emerged, or what's emerged from that process. It's the latest version. We've added to it and refined it since Charlie last came and spoke to the board. And there's a couple of things I just wanted to say about it very quickly. So one is systems maps can look very complex and quite academic, but I think the important thing to bear in mind is it is just a tool or a means of capturing what people think is important. So the conversations behind it, which you don't see on paper, are in some ways what really matters, along with, very importantly, where and how people looking at and engaging with the systems map think they see opportunities to make a difference, to make change. And the other thing to say is it's not a definitive picture. It doesn't try and capture or set in stone a final view of the world. But what it does do is show what the people who've made it and contributed to think is important, and allows people to agree, disagree, add to, and change. I didn't want to go into it in too much detail, but I will share the link with the minutes for board members to dive into if they would like to. But I wanted to just pick out four rather key themes that have emerged from it. To kick off, we focused on the barriers physical and mental health can put in the way of people moving more, and the pressure that non-communicable diseases puts on the system. So squeezing capacity and resources for prevention, something we've already spoken about today, and that includes squeezing the resources enabling to promote and support physical activity. And also, from what people told us in producing this map, rolled in with that was the culture or expectation that ill health can be treated at the expense perhaps of individuals, each of us feeling that we have power or control over our own health and well-being. So we also focused on how the environments we live in can make movement challenging and sedentary behaviour sitting more convenient. And there's a lot to unpick in that. We covered quite a lot of ground, including how infrastructure can make walking and cycling difficult for some people, and how feelings of safety can prevent people from visiting or using particular spaces. So an example of that I've been speaking recently to Dorset Race Equality Council was how people from different ethnic backgrounds might feel unsafe visiting particular natural environments because of feeling unwelcome, out of place, fearing hate crime, and so on. And then the third sort of headline or theme is that we have a norm of not moving to contend with. So not being active is something that we might see and learn from friends, family, and others. And that norm is reinforced through those same channels. And it's not about blame or finger wagging. I think it's about recognizing that that norm is the result of lots of different factors, but we need to recognize that it has real power as a feedback loop that reinforces that behavior of not moving, being sedentary, not being active. And then our final theme was about the value that we place on movement in daily life. So, you know, we all face there's lots of competing priorities and pressures, and all of that weighs against moving and being active. So that might be the pressures of work and family life. It might be the commitments of other commitments outside work and family life, but all of that weighs against moving more and reinforces that pattern of sedentary behaviour. So the next thing we asked our stakeholders to do after developing that system map was the bit everyone always wants to get to first, the interesting bit or the exciting bit, which is what can we do about it, or asking them rather, what can we do about it, or where did people who contributed to this process think we have opportunities to make a change. And again, I think it's important to say that these are headlines, and they reflect kind of the shared views and perspectives of particular stakeholders. But I just wanted to share them with the board. So the first was that we need to look for, or the challenge, I suppose, around looking for more ways to build movement into daily life. The second was tackling the belief that being active means dedicating time and money to support exercise, and that's the only choice that we have to build movement into life, into daily life rather. And that's definitely not to diminish or dismiss the huge value of sport or organised exercise, but recognising that what works for some of us definitely doesn't work for all of us. And then finally, we identified, or stakeholders rather, identified an area of opportunity around the value and prioritisation based on car travel over other more active modes of travel. In getting to that point, one of the challenges that we've had from stakeholders is, do we know enough? So is the picture that we've developed so far from too narrow a perspective? So I just wanted to touch on that very briefly, because I think it's a really important challenge that we, Charlie and I in particular, have to bear in mind moving forward. And the first quote I've got on the slide comes from our online conversation on Active Dorset's website, and I just chose it as an example of a few we've heard from lots of different, from multiple angles, that underlines, yeah, I suppose the sort of accuracy of that insight that we heard from stakeholders. You know, it's being reflected from other angles. And then 37% is the percentage of people in 2020 who told Live Well Dorset the lack of motivation was a barrier to them being active. Money and finance featured, but there's a big chunk of people there who are putting forward motivation, or another way of looking at that is lack of value from movement and from exercise as a barrier for them. And then finally, on that last theme, 23% of people, or adults rather, in Dorset, that's the percentage of adults in Dorset who didn't walk or cycle for any purpose in at least once a week in 2019, according to the Department for Transport. So I think I'm rattling through there, I know, but I think the point I'm trying to make is we have to keep that challenge from our stakeholders in mind, but also I think, you know, there are ways to validate and reinforce, I suppose, the insights that they've been given, which comes from their own local expertise and understanding of the communities that they live and work in and with. So where next? From the input we've had so far, we've identified three kind of key areas for action. So the first is understanding how physical activity can deliver value for people who are less active in order for them to build daily movement into their lives. And another way of thinking about that, which I've heard others use, is asking where's the joy in daily movement? What is it that can motivate us to find new and different ways to be active in daily life? Then secondly, developing a system-wide approach to reframing physical activity as daily movement and moving more, sitting less. I think even with a group of stakeholders that we've been working with so far in workshops in other ways, it's very easy for us to slip back into language of physical inactivity, physical activity, which then opens up for a lot of people in community, including people in communities. You know, what does that mean? What are we talking about? What's active enough? What's inactive? That kind of thing. And then thirdly, with stakeholders, we identified the need to increase communication of the benefits of daily movement, what it means, how we do it, and the existing opportunities, of which there are lots out there already, to be active. And as I said earlier, one of the challenges we've had is that we need to keep testing these insights and our assumptions as we move forward. We can't do this, we can't develop this approach in a bubble. So over the next few weeks, we'll be focusing on broadening, developing and testing those key areas for action and the systems map itself with others. So to give you some examples, local authority teams, voluntary and community groups, and so on, so that we can kind of, I guess, try and draw them into the process and develop some momentum or build some momentum around these three questions. So we want to ask them, do these themes for action connect with them, the communities and people that they work with, or do they have different perspectives, different pieces of the puzzle that we need to think about? And I'm sure they will. So if not, what's missing? What have we missed? What do we need to think about? And then finally, and importantly, if we're going to turn insight into action, how can these themes be translated into action that they can take, and what support do they need to make it happen? So this is my last slide, and I said at the beginning I wanted, if I could, to ask for a bit of help from the board. So I just wanted to plant a few questions with you, if I could, please. So the first is, it would be really helpful to get a sense of whether the board thinks we're moving in the right direction, and are there opportunities that we've missed? Are there things that we've missed from our insights process, and are there opportunities to connect with other bits of work that we need to know about it? And then also, it would be good, particularly bearing in mind what Charlie and the process or the need to reframe physical activity that Charlie and I have suggested and spoken about. What is it that you think you could do, perhaps individually or through your organisation, to normalise the idea of moving more and building movement into daily life? So that is the end of my presentation. Thank you, Chair. I'll just end the slideshow so I can come back to the screen.
Thanks very much. Do you think you could use leave the three questions on there?
Yes. Yep.
Just not that we can answer them today, but it might be that everyone can take away and sort of think about where they can take those back into their organisations or into the communities that they represent. But are there any questions to Rupert at this stage? Martin.
Thank you. Rupert, I'm sure you might be aware that obesity, obviously, and activity are interlinked with each other, aren't they? And there's now a new drive to reduce obesity in primary care. And we are actually incentivised now to identify our obese patients and refer them to Live Well Dorset to get the dietary advice. But actually what they need is the movement and activity advice as well, isn't it? So can you link this work in with that work programme that's going to go on through Live Well Dorset, because you're going to get an enormous cohort. We're a small practice. We did a sample of ours and we've got 700 and something obese patients. And so there's going to be a huge drive to reduce obesity, and we can piggyback the activity onto that because it's integral to making these people better. We did a bit of work, a lot of you will know Naomi Mason, where we took this into schools when we were allowed to go into schools and hold assemblies, and gave them activity booklets, and it didn't have to be going out and having a run. It was going out and using this wonderful green gym that we all live in, spotting things, looking for things, doing things that some of us who are old enough did as children, which involve movement and activity. And I think that's an area you put children and young people up on there as one of your slides. That's an area we've really got to concentrate on. And the method we used in that book was, you do it, go home, make your parents do it, get your parents to do it with you. So you're bringing the whole family on that activity journey. And I think that they're a very important tool to educate their parents. So I think there's two streams there. Can we get back into the schools to do it as we did in Mid Dorset very successfully? And let's use this obesity agenda to piggyback and dovetail in with this bit of work.
Can I just come back on that quickly?
Yes,
Chair. Yeah, I think the only thing I want to say was thanks, Martin. That is really helpful, and I think something we are bearing in mind, or have at the forefront of our mind in this piece of work, is there is a huge amount of good work already going on out there, and through this process there are opportunities to identify a lot of that, including what Martin has just spoken about, and share it with others, spread it, across the patch to other areas. So thank you.
I'm not seeing any more hands, but there are some really helpful comments in the chat bar, Rupert, which particularly Danny and Sam. But I would say that this is your place agenda, isn't it? This is your community, your neighbourhood agenda, and starting off with what Martin just said. Oh, John Selgren, just the person to ask about this, because he's the place person and the neighbourhood person. But what Martin was saying about 700 just on a GP's surgery list is just, almost a bit shocking and staggering. But that's where we need to get to. John, can you help with this?
Thanks, Chair. Really appreciate it. And I also enjoy the whole meeting. I always particularly look forward to this item and that sort of challenge in the data that we get in this session, the opportunity to look at the opportunity to increase physical activity. So again, in a sense, I think that's what you were hinting you might invite me to comment on at this point. And I think for me, it's taking all those things that people will do anyway, perhaps through COVID and other things or illness or whatever, just got out of the habit of. And as we know, some of the ways that we're encouraging people back into exercise is those simple things. So I remember things like the bus stop campaign, where for people who took buses, it was, look, rather than go to the nearest bus stop, just go to the next one and get that little bit of physical exercise and the same on the way home. Very conscious, lots of other things that we do day to day. Many parents and others, carers, support young people in walking buses and those kinds of issues. Another opportunity to do something that comes quite intuitive. And then those simple things like, walking the dog and taking children to school and so on. So I think it's important we remember that what we would try and do, and I think if I've read the content of the presentation correctly, it's that taking what people will intuitively tend to do on a routine basis and just try and accelerate that. This is not about sort of forcing people to get to sort of huge exercise regimes and programs. I mean, many do, and we hope they do indeed do that. But it's about recognising that the journey into that good practice is often around doing that routine day in, day out thing, which actually builds not only good health, but also a good habit in terms of remaining active. So I think, Chairman, I hope on another occasion, just conscious of time this afternoon, that we perhaps might explore, because the sense I've got is around this table, we've probably got considerable wisdom and experience of a vast number of those very, very practical things. I think if we sought to build our promoting greater physical activity programme from that starting point, we'd probably have a greater chance of success and moving the indicators that we want to, rather than assuming that we'll naturally jump people into, in a sense, the heavier top end of strenuous exercise. I think that's helpful.
It really helpful, John, and actually Danny's just put in some statistics in, and Sam's commented on them, and I'm just thinking, and I'm thinking just now in a minute, that actually, in order to drive some of this agenda forward and to help particularly the place agenda in the context of the council, they're quite shocking statistics, some of these. But there is, as you were saying, there's the everyday, what can we do about it? I'm thinking we need one of those 82 member council webinar and shock them agendas, because in fact, to draw out a lot of what is going on, and I talked to, I can't remember who it was, sometime earlier this week, that every councillor has at least one GP practice in their ward, most likely, or within a mile of their ward. It really, really close, and matching the two. Not that we want to provide any more work for GPs surgeries, but that is the link we're almost trying to do. It is trying to get people away from the GP surgery, but by empowering them by knowing what they can do other than walk into their GP surgery, i.e. go for a walk or do what you were saying, John. So I'm thinking that maybe there's one of those Thursday sessions that we need to to bring on, because it will also, thinking of your directorate, John, help with the, I'm afraid to say it comes back to finance. And there are things that I know need to change within the finances of what we provide on the ground for what people commonly say is leisure, but is actually organised exercise. Danny.
Thank you.
We're running late, I'm afraid, but
it was just a quickie to say, I mean, that is exactly the role of our social prescribers in general practice, and we are strengthening the numbers with the additional roles we can employ through the contracts to signpost and give patients that support. So they can be referred by receptionists, anybody in the practice. It doesn't need to be a GP or a practice nurse. And I think, you know, we are advertising so people can contact them without being in touch with the practice. So I think that would be an area if we can really work hard on that. And we were in talks with the Leisure Centre before COVID about setting up our pre-diabetes education sessions there, so people could actually get in the Leisure Centre, see what it was like, and start to build those relationships with other people in the same situation. So absolutely, it's all about the whole community coming together to support these patients, people.
Brilliant. Yes, it is. It's there. We just need to accelerate it, as John and Rupert were saying. Forbes.
Thanks. Yeah, thanks, Rupert. Just two things really. You mentioned, you know, the very clear links between, well, it's exercise and stroke, obesity, and non-communicable disease, and it's not just heart disease, of course. It's not just heart attacks and strokes. Cancer is the obvious one, but which is still, I think, under-recognised, and there's increasing information through our dice actually that's sort of demonstrating things like that. And the other thing just to think about, and not for a decision today, is the public sector workforce in Dorset. Is there anything that as employers we can do to promote that through our workforce? Because it's the biggest group that we have within Dorset. You know, it's what's it, about 30,000 or something in total employees through the various public sector organisations, and you just wonder if there should be a strategic drive somehow. It needn't be necessarily costly, but I know time is an issue to try and just promote that as and lead by example, quite honestly. Practice what we preach.
Yeah. Thanks, Forbes. Walking meetings, all that stuff. And it is, it's whether it's the local authority or the NHS, we're absolutely good reminder on that. Spencer.
Yes, just very quickly, Rebecca, I'd like to take you up on your suggestion about a member webinar on this particular topic. I liked the messaging I heard this afternoon, some of the graphics, keeping it simple, but really sound messaging. And it's probably something we can take down beyond the members. We can then use it with our officer group as well. I think it's a really strong message. So outside this meeting, you and I'll have a conversation, and we'll work out date, time, and what it looks like. Okay.
Brilliant.
Happy
Thank
to do
you very
that.
much, Spencer. That'd be fantastic, and it is about that social prescribing, isn't it? I think it'd be a brilliant one. I know this is everyone now. It's come alive, and we've got one more item, Rupert. But it seems that you've got a lot of people who really want to help here, practically on the ground. And I think that's what we need to take away from this. But your evidence really helps us get motivated, because things need to change. But Rupert, I need to move on to the next agenda item.
Thanks, Jan.
Thank you very much. Contacted either by Spencer or me, along with others, to arrange that meeting in particular. So next item on the agenda, and I apologise to Vivian that we're running a bit late here. I had it down till 4:10. I don't know if you can do it in 7 minutes, but it's really important, so don't worry if you can't. Item number 10 is hospital discharge programme, and there is a recommendation, and we have to make a decision under delegated powers the same way as we did with item number 7. So over to you. I see we've got Leslie and I think it's Les. Yeah, and Vivian. Thank you.
Great. So Chair, thank you. Thank you very much.
can I just come in, Vivian? It's Laura Miller.
Hi, Laura.
Yeah, sorry, I've had some IT issues and so I don't want you to think that I'm rude because I haven't got my camera on. I've had to rejoin on my phone. So I am here and I am lurking, and I apologise.
Good, you're there. Thank you.
Thank you, Chair. Conscious of time, in view of the temporary arrangements, I, as the Exec Director for Adult Social Care and Housing, will be asked to take the decision under delegated powers. Therefore, Leslie will take us through the paper and lead the debate, and I won't take part in the debate that will lead to the minded to view from the board. So over to you, Leslie, to talk us through the BCF and then the HDP3 funding. Thank you.
Thank you. So then thanks, Vivian and Councillor Knox, for that introduction. So my name's Leslie Hutchinson, and I've recently joined Dorset Council as the Corporate Director for Adult Commissioning. So there are two parts to this conversation. Firstly, it's around the Better Care Fund, and I just want us to note as a Health and Wellbeing Board, please, that ordinarily you would have received an annual report on the Better Care Fund that the Health and Wellbeing Board would be signing off or discussing. There wasn't a requirement to do that last year because of COVID and the impact of that. So one wouldn't have come to the board, but I don't think it had been noted during your previous meetings that wouldn't have been there. So from an audit perspective and for the purposes of the board having things all lined up, if you like, I just need that to be noted in terms of the minutes, that the Better Care Fund has been spent in accordance with the requirement of the fund, but there was no requirement to bring it formally to this group. So I hope that's okay. That's the first part. The second part of this conversation is about the hospital discharge programme, and that's the paper that you've got. It's a very brief paper. It's been brought to the Health and Wellbeing Board today because for the first time there's been a circular sent round from the Department of Health that has asking for Health and Wellbeing Board's involvement where possible in the planning and decision making around the budgets in terms of the hospital discharge programme. The programme itself has been in place since March 2020. And it's gone through various iterations, actually. It's government funding that comes down, and it does exactly what it says in terms of its title. It supports services through the CCG receiving the allocation. It supports services to make sure that people are discharged safely and swiftly from hospital. And it was brought in primarily because of the impact on hospitals and people in hospital through that COVID period when our figures were rising. It's continued to be in place, but the eligibility criteria and the way that the money is drawn down has changed slightly, and we are now on what's called the third part of it. And what that means now is that the funding has gone down, being free from the point of discharge from it was free totally in terms of services received. It then went down to 6 weeks, and later on during this financial year, it will go down again to 4 weeks. What's also happened, though, as a result of this latest change is that there is a cap on the budget that the system will get in order to make sure those discharges are done safely and swiftly. And we are working with the CCG and colleagues at BCP, and I need to add as well that a similar paper has gone to BCP Health and Wellbeing Board for discussion there. We're working with colleagues to look at how we are going to manage within that financial envelope and what impact that's going to have on the system, on provision and on safe, swift discharges. So what we're requesting today is that that the Health and Wellbeing Board agree as part of their forward plan to have a very full agenda item which details all of the impacts of the hospital discharge programme, including looking at activity rates and looking at the financial impact of it, at a later meeting in the autumn, and we will work with CCG colleagues to develop that paper and BCP colleagues actually as well. So we're requesting that you do that. But secondly, what we're needing to request is with the recommendation is that you delegate authority if any decision is needed to be made to Councillor Miller in conjunction with yourself, Councillor Knox, as Chair of the Health and Wellbeing Board, and with your Vice Chair. Subject to it going through the CCG and the local authorities' usual governance processes. So I don't really think I need to add much more to that at this stage, unless there's anything further anybody would like to ask.
Thank you very much for that explanation. We have got the paper. I haven't seen any hands up at the moment. Laura, do you want? Oh, shall I just? I'll come to Forbes, but Laura, you might want to follow up after Forbes. Hi, Forbes.
Oh yeah. Okay. Thank you. So I've read what's been submitted, and that's helpful. Thank you. I think it would be helpful to have a quite detailed conversation through the Health and Wellbeing Board about how we jointly fund this activity, because quite frankly, it's not straightforward and it's not easy, and it actually gets to the nub of the how we work as partners to try and address these difficult issues. And they are difficult issues. They're difficult for health and they're difficult for the local authorities, but they are about the needs of the population that we jointly serve. So I'd really welcome that conversation. So I stand happy to support it if asked to delegate authority. I just was checking that, you know, those of us that sit within the governing body of the CCG aren't conflicted in this conversation. We're not in this decision, I don't think, but we are involved in decision making within the CCG and the CCG's approach to this. So I just wanted, you know, just to acknowledge that, just in case that could be felt to be the case. That's all.
Leslie, do you want to just assure Forbes that this is for a very short period of time, and I've asked, and so's Laura and Leslie and Vivian will bring back in the autumn a much more detailed paper, because it's really important, Forbes. So Leslie, can you just confirm that for us?
Absolutely can confirm that, and we need to be doing the paper jointly. It can't be from one part of the system. It needs to be a combined approach to this. And also, just to give you assurance, this paper, before it was circulated to CCG colleagues in advance of coming here, so it hasn't come without CCG approval in it. So I just wanted to have that on the record as well, actually, if that's okay. Thank you.
It popped up quite late in the day, didn't it, as well? There wasn't much notice of this, but I just wanted to check. Laura, I don't know if you're still there. Do you want to say anything?
I am here. Thank you, Chair.
Good.
I can't put my hand up on my phone.
That's right.
IT has let me down. Yeah, thank you. I'm grateful for this. I echo what Leslie says. You know, Forbes is right. This needs a greater conversation, I think, and the intention to bring it back in the autumn, where we can really, you know, really go over that. And actually, the discharge from the acutes is sort of, I suppose, emblematic of the wider challenges facing the sectors and how we work together. And so whilst this is a kind of, you know, the delegated authority is what we're asking for, I also welcome those wider conversations too. But you know, this is what we're asking for here and now today, in order that we can do that work. And as Les said, it has been shared with CCG colleagues. So really, I'm not sure if I'm allowed to support this, seeing as I'm the one asking for the delegated authority for Rebecca, Forbes and me. But if I am allowed, then I support it. And if I don't, then I hope that the board will be minded to support it. But I'm probably not allowed to express that either. So I'm just checking the process, because it is a slightly unusual process. But thank you, Chair.
Okay, and just to clarify the recommendation, I noticed that Vivian hasn't actually said anything. Les, where does Vivian get delegated it to give rise to it, i.e. to enact the recommendation, having been delegated that from the portfolio holder via Forbes and I? Would that in conjunction with me and Forbes, would that be right?
Well, she's nodding.
Yeah.
I can see her nodding. So
It is slightly unusual situation.
It is an unusual situation,
yes,
with us not being in a face-to-face meeting. So we're really complying with that, aren't we?
I think that's what we do.
So are you happy for me to recognise the board-minded to decision, Chair?
So I was just going to come to saying, right, I'm going to ask the board to, you've read the recommendation, which is on the paper. Unless I hear otherwise, I will go ahead and say that is accepted. But I do have to ask if anyone abstains. No one's saying anything. And if anyone is against, but no one's saying anything. So Vivian, you've seen the recommendation that we have in front of us, and we just need you to say that you will enact that alongside Laura. We can't see Laura, but I'm sure she will as well, to the best of your ability.
Thank you, Chair, and most certainly will. I recognise the board's minded to decision, and thank you for your support, and we'll work with Laura and you as the Chair and Vice Chair, and we'll ensure that the decision is properly recorded and as discussed, and I'll make sure that I do that with Fiona. Thank you, Chair.
Okay. All right, Laura.
Thank you. That's perfect. Thank you, Chair.
Okay. Right. Sorry, we're 5 minutes over what I had on a running time. Any urgent items?
No urgent items, Chair.
And is there exempt business?
No exempt business.
Thank you all very, very much. That was quite packed. It was running ahead of itself at the beginning of the meeting, and suddenly things got very interesting and people got involved. But that's the point of the meeting. Really interesting and lots to follow up. But thanks everybody for sparing your time and being so engaged in the agenda. And thanks, Fiona, for all the help that you give me in making this all happen. So goodbye and have a good afternoon, evening in the sun.
Thank you, Chair.
Bye.
Bye. Thank you.
Thank you.
Thank
Bye.
you, Chair. See you next
Thank you.
time.
Bye.